a lot of the women that I'm seeing are in their 60s and 70s. So they were part of that generation that just got absolutely screwed by the WHI and the impact that it left in the wake, like the decade after. That's when they went through menopause. So now we're having this conversation for women that are 10 to 20 years out, over 20 years out, and sometimes over 30 years out from menopause. Is it safe for me to start hormone replacement therapy now? What are the risks? What, like I was told, whatever, all the cancer stuff, like all of that stuff for women that aren't on it. Can we start it now? And so we had to really dig deep into like, when are we comfortable doing that?
Dr. Doug Lucas, I am so excited to have you on the Root Cause Medicine podcast because I couldn't think of a better person to bring on than you to talk all about hormones and bone health since you are the bone health expert. So, welcome.
Thank you so much for having me. I look really forward to sharing this with your audience.
Well, we've talked a few times. We've covered some Instagram lives, but in the podcast, we get to go a little deeper and a little bit longer and with no technical issues. So, we're just going to jump right in. The very first question I want to ask you is it possible to reverse osteoporosis?
Yes. I feel like I'm on the stand. Yes.
Your Honor.
Yeah. Longer answer. Absolutely. And this is a frustrating thing that we see. A lot of people come into our practice or into our communities or wherever in comments on YouTube, and they say, my doctor told me it's not possible. I have to take the drug. It's the only thing. And it's just not true. We see it, I mean, literally every day in all of those things, that all those places I just said. People can improve bone health almost regardless of age. We can get into that a little bit. But almost regardless of age, we can improve bone metabolism. There are so many things that can be done, so many tools that could be considered. So, yes, absolutely, it can be reversed.
I love that strong, solid answer. And before I get into all the how, I need to walk through the journey of how did we get there? How did, because I have a lot of women that go, all of a sudden, I was diagnosed with osteoporosis. I was told, and I don't know how I got there. How did my bones move to trash? What's the journey to bone loss?
Oh, and this is so frustrating. I talk about this a lot because I think it's really important to understand that we don't, our goal is to try to figure out why you're losing bone, but we often don't know actually how quickly are you losing bone because we don't know your starting point. And I think we are going to see, as I am strongly encouraging, and I'm sure you are too, women especially, but also men, get screened early, especially now that we have ultrasound screening devices. You can do it at any age. I think that everybody should probably know what their peak bone mass is, which means that they should be screened in their 20s or 30s. And so if you knew that, then you could say, well, I have great bone mass. I don't really need to worry that much about it, although you might want to anyway. Or you could say, oh, my starting point's not very good. And I should probably make sure that I'm always doing resistance training and impact training and getting adequate nutrients. I should be really careful with dieting. I should be really careful with birth control. Like all of these things that we know are risk factors, you should be like red flagging all of them because all of them could have an impact. So knowing your starting point is the number one thing of like, how did I get here? I'm like, I don't know. Maybe you've been there for 50 years. I have no idea. But assuming that they're losing bone, the question is, why are you losing bone? How did you get here? And oftentimes we do see people come in with multiple DEXA scans, or bone turnover markers or whatever it is that they're measuring, and they are getting worse and worse and worse. So then we really need to say, all right, well, how do we slow down and stop this bone loss? And then how do we turn it around? But oftentimes I would say probably top three would be postmenopausal women not on HRT. It's not the only reason, but it's a good one. Not eating enough food in general, just malnourished because of decades of chronic dieting and bad nutritional advice, inadequate protein, and then sort of the wrong exercise, thinking that walking is impact and running is impact. And these are things that are going to build bone and they're not. So like that would be like my top, what did I just say? Four? Those are probably my top four.
Okay. All right. That's pretty solid. Now, you mentioned two forms of testing bone turnover markers and then, of course, bone imaging. Let's break that down.
Yeah. Well, let's talk about imaging first, because everybody's heard of DEXA for the most part, especially if you're a postmenopausal woman, you've heard of DEXA. I want more premenopausal women and perimenopausal women to have heard of DEXA too. DEXA is an X-ray, and it is kind of like a fancy X-ray. You lay on a table, and this thing goes over you, and you kind of feel like you're on Star Trek. If anybody, I just dated myself, but if anybody remembers that show, and it'll tell you your bone density, which is like the mineralization of your bone. Like, what does an X-ray do when it hits your bone? And it's the gold standard by default because it was decided to be so, which is unfortunate because it's not a great test. It is abundantly available. It's all over the world. So we kind of are stuck using DEXA for the time being, probably for the actually foreseeable future. But we need to know what DEXA is. but it only is a measure of bone density. Ultimately, though, we care about fracture risk. Density is a part of that equation, but it's also bone quality. And DEXA does not tell us about bone quality. There are a couple of add-ons to DEXA, one called TBS or trabecular bone score that some DEXA machines have, which gives us a sense of bone quality, but it's still coming from the same data. So you're still using a two-dimensional X-ray to get that information, and it's not particularly helpful. Sometimes helpful. So if people have access to it, we'll look at it, but I don't specifically have people search it out. That's the standard of care. One thing about that I didn't mention, the reason why I call it not a great test is that it has quite a bit of variability from scan to scan. So you have to get, hopefully, from the same imaging center, the same machine, and preferably also the same person in the exact same environment that you had the first time, which obviously is very hard to do, right? So if you have a different person who's doing the test, they might position you differently. If it's a different scanner, it's going to have a different bone mineral density. So when you compare your first scan to your follow-up scan, if they're from different scanners, you have to accept that there's going to be some variability. And some people would estimate that plus or minus 4%. When we look at improvement in DEXA, we're usually looking at like the 1 to 2% range. So it falls within the error, like the range of error of the test. And so that's really frustrating because people will say, look, I got better. I'm like, well, maybe you might have gotten better. You might have gotten worse. We actually don't know. So then we need other forms of testing, and there are a couple things out there. So the one that is catching a lot of traction, and I've been people have been reaching out to me that are buying these machines and setting them up in different areas and gyms and hospitals, and I'm super excited about it. It's a company called Ecolight. They're Italian. And they have a machine called a REMS, and REMS is an ultrasound device. So it looks like the same ultrasound device you would see in your OBGYN office, the same thing you would do like a transabdominal ultrasound with. And it is specifically designed to look at bone, which is funny because like when I was trained on ultrasound, we were trained like ultrasound can't see bone, but apparently it can. And so they Ecolight created this database of essentially trying to figure out fracture risk of over 15,000 individuals. So now when you get a scan, the machine will interpret your bone quality, what the sound waves are doing as they move through three-dimensionally through the bone, and then compare it to this very large database. And it can come up with a T score, just like a DEXA, but it also comes up with a fragility score or a bone quality score. And so now we have both sides of that equation. And we'll say, well, we know your bone density is this, but your bone quality is this. And we've seen that go both ways. You think like, oh, it's going to be better, but not always. So we've seen people that have very poor looking DEXAs that have great looking REMs, good bone density and good bone quality, and we'll talk about what we do with that. But I've also seen it go the other way, where people will have, maybe not a terrible looking DEX and they get on a REMS and it looks worse and they have poor bone quality. So then we say, uh-oh, like we have a bigger problem than we thought. But what's great about that is that it responds faster to treatment. There's less variability from scan to scan because the computer is actually deciding if the scan is acceptable. The positioning of the body doesn't matter as much. Like I just had mine scanned yesterday, and actually I was talking with Dr. Kim Zambito, who's like a great thought leader in this, and she was doing my scan, and I was asking her like, does the position of my leg matter? And so she showed me. She was like, we scan it here, internally rotate, scan it here, externally rotate, scan it here. It comes up with the same data because it's not a two-dimensional image, which I thought was really, really cool.
Huge.
It's huge. Yeah. So REMS, I think, I don't see the path forward that it takes over DEXA, but I do see the path forward that it becomes in the cash pay space, it becomes the second test after DEXA to make sure that it's accurate. And then when there's disparity, then there's some other things we can do. But those are the two major forms of testing that are available right now.
So going back to the idea of T-score, people get their T-score, their Z-score, they're like, "I have no idea what this means. All I know is that I was told my bones aren't great." Can you explain that?
Yeah. So we'll start with T score because that's what the diagnosis is really based off of, and then I'll get to Z score. So T score is a statistical analysis of your bone density compared to an race and gender matched person of like peak bone density in your group, right? So like if you're a Caucasian female, a 20 something year old Caucasian female, you're comparing your bone density now, if you're 55, to that 20 something year old female, which doesn't seem like a fair comparison, right? Like you're like, well, why should I compare myself to a 20-year-old? Like I'm 55. But they do that because we want to know how much bone have you lost from what should have been your peak. But I already said, like, we don't actually know what your peak was. So we're asking the question of how has your bone degraded from what is the average for your gender and ethnicity. And that is then delivered in standard deviations. And so if this gets like deep into statistics, but standard deviation is like a bell curve, or like most people are close to the middle, and then less people as you get further and further out. So T score is usually delivered in a negative number, and that means it's a certain number of standard deviations below the average or the mean. And that standard deviation of -1 is the threshold for what's called osteopenia. So T score of -1 is the threshold for osteopenia, and then it goes down to -2.49 technically, or 2.5, which is the threshold for osteoporosis. So when you say I have osteoporosis, you're saying I have a T score that is more than 2.5 standard deviations away from the average of a gender and ethnicity matched person in their peak bone mineral density timeframe. So that's what T score means. But it is a statistical measure, and it is making a lot of assumptions, because you could say like Caucasian women are different than black women. That's true when you look at bone density. So you have to separate to some extent, but at the same time, there's a lot of disparity within like those ethnic groups as well. And so we see, especially in very small framed, lean Caucasian women and Asian women, you see on average much lower bone density. And so I think that they are overdiagnosed with osteoporosis. And this is a great example where they would say, then get a REMS, and their REMS looks great. And we see that often, not all the time, but often. So again, another reason why DEXA is not great, because T score is not a great metric, actually. It is, again, we have to use it, but it's not perfect. And then you get to Z score. So Z score is the age matched version. So if you're 55, your Z score compares you to other 55-year-old women or men, depending on your sex. This is really not used in the postmenopausal timeframe, though. It's used in the peri and premenopausal timeframe. So before the age of 50, especially, you want to know comparatively what is your bone density. But we're not actually even talking about osteoporosis generally in that time frame traditionally, although honestly, I have patients in their 20s, 30s, and 40s. So it does exist. But even when that's the case, I still use T score over Z score because that's what we use for osteoporosis.
Okay. And then now let's go. So we have the imaging options. Let's go into the bone breakdown markers. And how do we test those and what are you looking at?
So we call them bone turnover markers. There is a bone breakdown marker. There's also a bone building marker. So it's the turnover of bone. I call it the metabolism of bone. And this is what I really think the definition of osteoporosis should actually include. We need an imaging metric. I get that. But really, osteoporosis is a long-term imbalance of bone building and breakdown. You have too much of one. You usually have too much of a breakdown. It's not common you have the other. So really, we're saying, what's happening to the bone breakdown? What's happening to the bone building? Are there blood tests that can show us that? And the answer is yes. And so there are some older ones, there's some urine-based ones, but in the modern era of bone health, we use these two tests. One's called CTX, or C-telepeptide. The other one's called P1 and P, and I'm not going to list out what that means, but you can just look up P1 and P and you'll find it. And so CTX is the breakdown marker, P1 and P is the building marker. What's really cool about these is that they change much more quickly than does imaging. So you can imagine, like, as somebody who's trying to help people reverse osteoporosis naturally, if I had to wait for their DEXA to change, I might not see a change for 12 to 24 months. That's a really long time to perform an intervention and then hope that it's headed the right direction. The bone turnover markers are going to change in a matter of weeks. And so we can use these to see what the intervention is doing, especially when we're talking about adjusting hormone doses. But we can use these to see like what's happening in a much shorter time frame. One more thing on that. When people start using these, there's a lot of confusion, because you would think that what I want to have happen is I want the breakdown marker to slow down and I want the building marker to speed up. And I thought that too, but that's not really how it works. So bone metabolism is pretty smart. If you increase bone building significantly, you actually have to increase bone breakdown too. And so you can't just do one by itself. And if we talk about drugs, we'll see why this is a problem, because that's what the drugs do. They sort of break bone metabolism. But if you're doing it naturally, they will move together. So that's why we started using the ratio. So there's several studies that actually use these same bone turnover markers, and they use this ratio. And I thought it was so brilliant when I saw it. I wish I came up with it. But basically, you use the building marker over the breakdown marker, and then you have to adjust for units. And so it ends up looking like a two-digit number over a 0 point something, something, something number. And when you do that, you end up with a three-digit number between 100 and 300. Higher is better. And so then now we have a very simple range where we can say, oh, your ratio is 100, is pretty low. You're probably not turning over bone very quickly. You might not be building bone very quickly. And our threshold right now is 150. We're still kind of trying to decide if that's right, but the higher the better. So we see people that will come in, they have low bone turnover, and then if they repeat their metrics at 6 weeks or 3 months, and we see, wow, like now it's 200 or 250, like, oh, I'm very confident that you're headed in the right direction. I think your imaging is going to look great, right? And so it's a very powerful tool to use as we go forward in the bone health journey.
And is this ratio like, let's say somebody listening to this is brand new to all of this, but they've managed to convince their practitioner, whoever that is, to run these markers. Is
Good
this
luck.
ratio well, I know. So maybe they're seeing somebody functional. Can they find this ratio online? Is this something that there's a plug and play option, or do you actually have to do long math on this?
You have to do long math. I have videos on it on our YouTube channel, and in our community, we have I think we have a whole like channel on on this because it's important to do, and it's not hard. You just have to do it right the first time, and then you'll figure it out. But like moving the decimal point over is it's like takes you back to like early high school, I think, or middle school math. Yeah.
Okay. All right, perfect. Now, in your perfect world, or let's even say your clinic, do you have people get all of the above? Do they get a DEXA, a REMS, and do a follow up with the breakdown, or do you pick one over the other?
So generally, people are coming in with a DEXA, so they have the diagnosis. Sometimes they have a REMS. For the most part, I think if people have access to a REMS, I think they should get a REMS because the DEXA, we just see so much disparity between the two. We know the DEXA is not particularly accurate for certain populations. So I would love to see a REMS because what I hate to see, and this works both ways, I hate to see people that have a diagnosis of osteoporosis have great bone quality and then they're freaking out about their bone, right? They're afraid to live life because they're afraid of fracture, but they're actually fine. And I've totally seen that. But then I've also seen it the other way where their DEXA looks okay. And then for whatever reason, they got a REMS and the REMS looks terrible. And you're like, oh my gosh, or they have a DEXA and they've had a fragility fracture. And they're like, well, but I don't have osteoporosis. Remember that over 50% of fragility fractures occur in people that don't have osteoporosis. So it's the definition, it really needs a lot of work. So I recommend that we get a DEXA, get a REMS to verify. If they're wildly different, you also use this thing called VBQ or vertebral bone quality score based off of a lumbar spine MRI, just a regular non-contrasted lumbar spine MRI, which could actually serve as the tiebreaker. So then like you can really figure out, man, how aggressive do I need to be here? And all of those imaging modalities are looking at bone a different way, and they could potentially give a different result. So I think more better. And then bone turnover markers are great to know what your starting point is. And then moving forward, those are going to change more quickly. So that's we don't repeat them that often in most patients. Usually we're doing labs every 6 months. But the way we operate is people have like a lab budget. And like if we want to get them every 6 weeks, we'll get them every 6 weeks. And so we can just burn through that, get them more frequently. We generally only do that though in patients that we're like helping to come off of Prolia or come off of a bisphosphonate, right? Where we're worried about rapid bone loss or fragility fracture that occurs after coming off of drugs. Like these are really big concerns that people have.
And then, on average, how much is a REMS?
Good question. So I was just meeting with a whole bunch of REMS owners. This is a pretty new space. So I think on average, I think the cheapest I've heard is like $199, and then it goes up to maybe 3 or 400. Some of it depends on what they're offering as a follow-up. So there are some, I mentioned Dr. Kimberly Zambito earlier. So she's an orthopedic surgeon, hand surgeon that also has a bone health clinic, and she'll do the scan herself. And then, she'll talk to you like while you're doing the scan, and you basically are doing like a consult with her at the same time. It's not actually her intent, but that's just sort of how it plays out. That's a very valuable, whatever it takes, 30 minutes, right? Versus some of the centers will have a tech who's doing the scan, which is what I would expect. It's not wrong. It's not physically hard to do. It's not technically challenging to do. And so the tech's not gonna be able to answer those questions like a physician. So then sometimes they would then offer like, let's have a consultation as a follow-up, and that's going to cost more money. And so it really depends on where you go and how they're doing it. My hope though is that we're going to get some consistency in how this plays out and maybe get some of the same follow-up information from center to center for people that have REMS. And that's something that I'm working on with a couple of different entrepreneurial individuals.
Okay. All right. So before we move into the next section, which of course is like, well, now what do I do? I want to make sure because I love analogies. So I want to make sure that we've kind of got this right and you're going to help me piece this together. And it might have even been you that I heard this analogy from. It's like looking at a house, right? So if you're looking at a house, we've all seen houses that are falling apart on the outside, which is the DEXA scan. But we go in the house and we're like, it's still falling apart. There's still holes. The whole place needs gutted. This is disgusting. Termites have taken over. This is awful. So like the REMs would be bad. And then we have people where we look at the outside and we're like, the house is completely falling apart on the outside. But we go in, and how many times have we seen on remodel shows where they go, well, it has good bones, pun intended, like, oh, everything looks great in the inside. It just needs paint. We just need to tear up this awful orange carpet. Like we can handle this. So now, again, it's like this, it's the same house. It's just the outside of the house versus the inside of the house. Do I have that analogy right when it comes to our
Yeah, I think
ish?
you can draw that analogy. I think, like, as an orthopedic surgeon, I get caught up in, like, well, the cortical bone responds to this and the trabecular bone does, but I think, yeah, big brush strokes, yes, I think you can make that analogy, yeah.
Okay. Now we've been diagnosed with osteoporosis. Now we find you on YouTube. We listen to this podcast. Let's talk about what you do. What does Dr. Doug Lucas do that is reversing osteoporosis in his patients?
Yeah, and the problem with this answer is that it's not one thing.
Of course not.
And I see, like, there are so many communities out there where people say, "Well, I took this supplement and I reversed my osteoporosis." And I'm like, "Well, maybe that might be true, but probably they were also doing other things in addition." Seen other influencers, like, especially in the menopause space, they're like, "I reversed my osteoporosis with this," and it's like, "I have an affiliate deal here, buy it now." And it's like, oh, it's frustrating because then people will, so if they trust that person, they'll be like, "Oh, well, I'll buy that thing. I have osteoporosis. I'm afraid of fracture." And then it's not enough. And so what we did when we started working with patients with osteoporosis, because this actually wasn't my plan starting my integrative practice. I really wanted to be like all things because I just felt like I should help people prevent dementia and heart disease, and osteoporosis kind of fell in my lap, and I learned to love it because osteoporosis really is a sign of all of the same things, but it's a very clear diagnosis and it's something that we can really help. So I just love doing that. And that's all we do in our practice. But we realized early on, like, this is really a lifestyle problem. It is a nutrition problem. It's usually a gut health problem. It's an intake problem. It's a protein problem. It's an exercise problem. It's a stress problem. It's a cortisol problem. Like, it's all of these things. So then how do we, like, we started out just by doing consults, and I would give people this list of like 1,000 things, like, here, do this, right? And it's totally not actionable. It's like a functional medicine, like, classic, like, just starting out functional medicine doctor thing, right? Here, do these 1,000 things, take these, 200 supplements, and it's all going to be good. And nobody can do that. And so we realized, like, okay, well, especially with this population, they're generally, like, their gut doesn't work well. We need to do the gut work. And so we just sort of, like, broke it down. We're like, okay, we need to bring them in a program. So we bring people in for 12 months at a time, minimum. We don't do anything shorter. I don't do consults. You have to come in and work with our team. They meet with our dietitian. These are functionally trained dietitians. A lot of them used to work for some of the functional medicine companies and actually explain these tests. Like, they have deep, deep knowledge, deep training in gut health. And so we ask all the symptoms, like, do you have symptoms of gut dysfunction? Let's do a stool study. Let's go down this pathway. And we find almost always there is dysbiosis, there is leaky gut, there is, low stomach acid, there's pancreatic enzyme deficiency. Like, all of these things are so prevalent in people with osteoporosis. They're not absorbing their food. And so we get that information, we get the serum labs, and then we start them on the lifestyle part, but we have to meet them where they are. A lot of, especially the women in this group, have never worked out. They've never lifted a weight, right? So then how do you teach people how to do some of these, like, complex things that we know are good for bone, like a deadlift, like a back squat? Like, there's a way to do it, but you have to be very careful because obviously we don't want to, like, tell them to do something and then they have a fracture. So we created this program that has a ton of content, a ton of touch points, and it can help to hit the lifestyle things, which is kind of our framework, as lifestyle starts with the lifestyle. And then we add biomarker driven targeted supplementation. And then we talk about hormones, and we do those three things before we would consider anything like pharmaceuticals. Occasionally somebody comes in and they are in such a bad starting point, or they're already on them, and we're like, okay, well, let's work this in, because we understand those too. Like, I lived in that world, but it takes a comprehensive approach. It really does. And it is different for every single person.
What about the fly by night or the very quick blog posts that are like, "Oh, you have low bone because you don't have K2," or "The reason you have low bone is because you don't have vitamin D." Like, when we talk about nutrition or even just these targeted supplements, how, like, in a percentage or on a level, like, how much do these play a role in the grand scheme?
It's really hard to know. it's such a multifaceted problem. And there are, people say like, "What's my cause of osteoporosis?" No, which is I'll just like turn the screen around, be like, it's all of these things. Could it be purely a vitamin D deficiency? It could, but we don't see that as often anymore, especially not in the cash pay space. Like my patients come in, they're educated, right? Like they're already on vitamin D, they're already on K2. Like they're trying to tell me why this K2 is better than that K2, and like it's awesome. I love that about my patients. But my patients aren't vitamin D deficient. Now, in the general population, is it still a problem? Sure. But I don't think it's vitamin D deficiency like they're not at 80. I think it's like real vitamin D deficiency, like they're less than 20. Like that's truly vitamin D deficient, right? So I think that could be it. Is it a K2 deficiency? Yeah, I mean, maybe, but we haven't really been replacing K2 for very long. Most people are getting it through diet unless they're avoiding animal products. So I don't know. I love it. I use it. But is it just that? Probably not. Is it celiac disease? Yeah, it sure could be. That's definitely a thing. Is it a woman with dysfunctional cycles who has progesterone deficiency? Yeah, absolutely, it could be that thing. So sometimes we can really find this one thing that's going to make that shift, but oftentimes it is a combination of things.
And when it comes to hormone use in your practice, about what percent of women end up being I ended up being on some sort of hormone therapy?
It's high.
Yeah, I
Now,
figured.
it's a very powerful tool. And so we have to have that conversation with every woman that comes in the door. And they should be having that conversation anyway. But of course, I think your audience knows very well what happened over the last 22 years. And so a lot of the women that I'm seeing are in their 60s and 70s, so they were part of that generation that just got absolutely screwed by the WHI and the impact that it left in the wake, like the decade after. That's when they went through menopause. So now we're having this conversation for women that are 10 to 20 years out, over 20 years out, and sometimes over 30 years out from menopause. Is it safe for me to start hormone replacement therapy now? What are the risks? What, like I was told, whatever, all the cancer stuff, like all of that stuff for women that aren't on it, can we start it now? And so we had to really dig deep into like, when are we comfortable doing that? But I would say overall, 90, at least 95% of our patients probably are on some form of hormone replacement therapy. Not all of them are on estradiol like I would want them to be. Sometimes it just doesn't make sense. And the times that they're not on it are usually like the hard things, like women that are over 20 years out from menopause with cardiovascular risk factors, women that have a personal history of breast cancer, and either it was a high, like a high stage and we're like, no way, or they're just not comfortable, right? Even if it was like a stage one, but they just aren't comfortable with it and their oncologist isn't comfortable with it. Like I'm not going to force that on anybody. So they're not on it, but they would benefit from it. Now, can they still improve is the question. And the answer is yes, but it's much slower.
And how often in hormone replacement therapy are you using, for example, testosterone? I've noticed the idea, the concept, the use of testosterone has suddenly become controversial in social media. I don't know why. So I'm going to ask you, how often do you use testosterone with your osteoporotic patients?
So we started out using testosterone more because again, I was seeing probably about equal men and women when I started seeing patients with osteoporosis. Obviously that's changed. Like the vast majority of our patients are women now. But early on, I was a big advocate for testosterone for men, diagnosing it in younger and younger men. I myself had been on testosterone for a couple of years at the time. So like I'm a huge advocate for TRT in the right population. So when I started seeing women and I realized the benefits of the androgens, testosterone, DHEA, the androgens for women and bone health, and even though most of the research is not on bone health when it comes to testosterone, there is evidence to support using testosterone in women. So we started using it, and it is an effective tool, and the literature supports using it. Obviously, it's off label because there's no commercial product anyway. But you can use it. But what I found is that as patients get older, so as women sort of pass the age of, if you want to use 60 as an arbitrary number, I find that they don't tolerate the side effects very well. And so I had a hard time getting high enough levels of testosterone without running into side effects of hair loss. And so most women over 60 are already worried about hair loss. Adding testosterone and seeing hair loss as a result of that did not go over well. And so again, like this pushed us to say, well, we really need to be focusing on optimizing estradiol and progesterone first, using testosterone where we need it. But what happened when we did that is we found that if we give women the androgen precursors like DHEA, we optimize estradiol and progesterone, we optimize their lifestyle, improve their gut, their adrenals, their thyroid, all of a sudden their testosterone comes back because it's primarily not made in the ovaries. So postmenopausal women, even in their 70s and 80s, can actually have pretty good testosterone naturally if you give them the precursors and they do the lifestyle work.
And then speaking of optimizing estrogen progesterone, I'm going to talk about progesterone for a second. You and I have had conversations before. Do you do progesterone continuously or do you cycle it even in somebody who's postmenopausal, meaning like 14 days on, 14 days off, etc.?
So I was just doing a talk yesterday, and one of the members of the audience was an OBGYN. And if anybody's heard me talk about hormones, you know that I never try to disparage doctors and throw anybody under the bus. But it is hard to talk about hormones and not talk about the fact that the OBGYN community as a whole does not view alternative options very kindly. And so this OBGYN that was in the audience asked me some really funny questions when I started talking about cycling progesterone, as if like she had never heard of it as an option, which is possible. But then also the way that she thought that it would, if we did this in women postmenopausally, they would have all of these symptoms. And then I pointed out like premenopausal women don't have symptoms. I mean, they might, but a normally functioning good levels of estradiol and progesterone cycling woman does not have significant symptoms when progesterone is removed naturally and then added in, and estradiol falls off naturally and then comes back. And so this is the same thing we can do in postmenopausal women. However, we are still in the process of sort of making this transition because I was trained to use static hormones. And actually, I was even trained to use bias, which is a whole other conversation. So we don't do that anymore. But we use estradiol, we use micronized progesterone orally. And when we made that shift, everybody was static. We're optimizing estradiol levels based off of biomarkers, using progesterone basically for symptoms, and then also watching a few other things. But everybody was static. And it wasn't until, I mean, it wasn't even that long ago that I even learned like this makes sense. I was taught by some people like you should really consider doing rhythmic because of the impact on the receptors and has all these potential benefits. And people passed me on the literature, and I was like, wow, this is kind of cool. But what really impacted me is that when I went back and looked at the early bone health literature, and by early I mean like in the 90s, early 2000s, where they were using hormones to see the impact of bone mineral density, the vast majority of those studies used rhythmic protocols. So they were cycling, although they were cycling progestins, but they were still cycling the progesterone side of it, and they were using either 10-day or 14-day cycles. So we have now made this shift because what we saw in those studies is that the bone mineral density impact was always better in rhythmic protocols. Didn't matter even what the level of estradiol was, rhythmic patterns always were superior when it came to bone mineral density outcomes. And so now we are in the process of shifting women over to cyclic. But where we are running into friction is if you optimize a woman's estradiol levels based off of FSH and bone turnover markers, and then give her adequate progesterone to cover her endometrium, but then withdraw that progesterone, we are going to see breakthrough bleeding in some women. So then we have to decide, are we going to go all the way down the rabbit hole of physiologic restoration and actually restore menstruation in postmenopausal women, which some women want to do, not that many of our patients want to do, or do we need to pull back in some manner and maybe bring the estradiol dose down, make sure we're still covering bone turnover markers and still cycle, or go back to static? And so we're kind of in this process now of figuring this out because now the literature supports doing it, but now we have to figure out how do we actually do it in clinical practice in a way that the patients will actually want to still be our patients.
Yeah, that is the truth because I think not bleeding anymore is one of the silver linings of going through perimenopause into postmenopause. However, you shared that one paper with me, and I was like, yeah, I would rather preserve my bone if that's what it takes, cycling my own progesterone for my own hormones. I want to go back to the FSH just really quickly before we move on to the medications because a lot of people have medication questions, so we'll wrap up with that. Let me start with this. In the bone literature I see, there is a minimum estradiol to quote get to, like 60 picograms per ml. And then do you agree with that? Do you go higher? Do you prefer their estradiol to be higher in most women? And then what do you want their FSH to be? Because everyone's trained, oh, your FSH once it crosses whatever, 40, 25 for sure. You're postmenopausal and there's nothing we can do. I'm like, oh no, there's actually a lot we can do.
Yeah, yeah,
But okay.
right. It's just a biomarker for estradiol, right? So you're the first person who's ever said that 60 number to me that I haven't told it to. For I don't know if I told it to you, but I don't
No,
think I
you
did.
didn't. No, I've read the
No,
literature.
yeah,
Yeah.
yeah. So kudos to Dr. Carrie Jones for actually being the only other person I think that knows that. So yeah, the literature supports somewhere around 60. We say 60 to 80. There's some variable numbers. And what's cool about that is it gives us at least a benchmark to say like, yeah, we should be driving estradiol up to 60 to 80. But we know that when we do that, the response is quite variable. So some women, like I well, I won't give too many examples. So some women, when we get them there, their bone turnover markers are still not great. CTX is still high. And so we're like, well, it's not enough. We're obviously not getting to the receptors. So then we need to drive them higher. FSH also at 60, I don't see FSH come down almost at all. For FSH to come down, estradiol is going to have to be higher for the vast majority of people. But what we're finding too, though, is like there are some women that can have, estradiol in like the 30 to 40 range, and their FSH is coming down and their CTX is coming down. And so they're just much more responsive on a cellular level, which is really cool. But that's why, when I hear doctors say like you don't need to test hormones, I'm like, how do you know? I mean, there's no way to know if you're not looking at the biomarkers.
Right. And what's really cool is FSH, so follicle stimulating hormone, which is a blood test for everyone listening. There's some really interesting data now on it as its own modulating hormone. Like, yes, it affects the follicles. That's its point when to help women cycle, follicle stimulating hormone. But on its own, it seems to play a bigger role outside of just reproduction, which I was when I read the one of the papers, I was like, oh duh. Like, of course it does.
Right,
You know,
right. Why would it just be one
obviously.
thing?
why why would it be one thing? But that's what we've been taught all these years. It's literally just one thing. And I'm like, dang it.
Yeah, so we've started looking at this now, and I mean, for a while we weren't even getting FSH on our repeat lab panel because we were like, well, like it doesn't matter. Like I just want to go off of estradiol. But now we do, and now we're seeing like, okay, well, estradiol is 60, 80, or 100. FSH is still 70. Maybe it's not enough, right? But then we do see women sometimes will come down to like to 50, 40, and 30. I think you asked me like what number are we going for? I think ideally it would be 30, but I don't have a long enough clinical history to tell you that we can do that reliably and not have symptoms of breakthrough bleeding with the level of estradiol that would take.
Okay. All right. Well, and then to wrap this up, I would be remiss if I didn't mention the bone medications, pharmaceuticals that are out there and how they were always the first line. But interestingly enough, they were not your first line in everything we just said.
Yeah. Yeah, no. So if you look at the recommendations from the NBOF, National Bone and Osteoporosis Foundation, World Health Organization, the drugs are always the first line because that's what the system is. I mean, we just have to accept that that's the system that we live in. When somebody has a T score of less than negative 2.5, the recommendation is going to be to start on a bone health drug. Generally, it's going to be what's called an anti-resorptive drug. Those drugs are the bisphosphonate drugs, your Fosamax, your Reclast, or Prolia, which is a very popular version, injectable version. And so the anti-resorptive drugs will stop bone loss by one of two methods, but one way or the other, shutting down the osteoclasts, the cells that break down bone, which sounds like a good idea, I guess, to some people. And the literature does support using them. They do reduce fracture risk, but only in the short term. Because, like I said earlier, bone metabolism is linked. So building, breakdown, they happen together because it's like a road. Like you like analogies. So here's the analogy of the road, which is if you want to build a new highway, you have to remove the old highway first. You cannot build a new highway on an old highway. It will fall apart. And so you have to take the old highway out. That's the osteoclasts for the osteoblasts to come in and lay down a new highway. So this happens in the bones. If you shut down the osteoclasts, the osteoblasts will stop working too. And we see this in the bone turnover markers. Somebody's on a bisphosphonate, their CTX, which is usually like, I want it to be, let's call it like 300. It could be like 10, right? They're doing nothing. Those cells have been poisoned. They're dead. They're not doing anything. But then the P1 and P, which is usually we want it sort of like high double digits, close to 100. It'll be single digits. It'll be like nothing. And you're not building bone. You're building enough bone that bone continues to mineralize. And that's why the bone mineral density looks better and fracture risk does go down again in the short term. But what happens if you stop reconstructing highways, eventually they all fall apart. Right. And that's what happens with these drugs. And that's why now you can't use these drugs for more than 3 years or 5 years because the bones become more dense, but they become brittle.
So what's their next option then? Let's say somebody's 50, osteoporotic, goes on the drug. Now they're 55, go off the drug, and have decades left to live. What do they do?
Yeah. And what's really crappy about this is usually they're 55 when they go on the drug, and then they come off the drug at 60 or 62, and then they're like, "Man, what are my other options?" Like, "Oh, I heard HRT is good. I saw Carrie Jones on Instagram, and she said HRT was good for my bones," and their doctor's like, "Nah, you're too old now." Oh, shoot. And so, yeah, this is the problem I have with drugs as the first line approach. I'm not gonna say that drugs should never be used. There is a time and a place, but I think it's for a very defined window. So let's say, for example, a woman who is undergoing primary treatment for breast cancer with an aromatase inhibitor, she's going to lose bone like crazy. Not a bad time to put those osteoclasts to bed, right? Like now we're using pharmacology in a smart way. And then she can come out on the other side of that treatment as a breast cancer survivor with good bone quality. That's a good deal. But if a 50-year-old who has the ability to use hormone replacement therapy, which is more powerful than bisphosphonates in just about every study I've ever seen, should consider other avenues before they would consider a bisphosphonate. Because you're right, there is no long-term approach. You have to jump from drug to drug. Each drug has slightly different risks. You could use the anti-resorptives and use the anabolics, like the Forteo and the Tymlos drugs. Those drugs are also very short-term, like 1 to 2 years. There is just not a good long-term approach with the pharmaceuticals. So unless you can't do the things that we talked about, you should really consider holding off on the drugs, monitoring the bone, making sure you're not getting worse, figuring out like how bad is your bone to begin with, and then come up with a comprehensive plan that doesn't include the drugs until you absolutely need them.
Amazing. I was just gonna ask you, like, as we wrap up, what's the one thing you wanna leave people with? And I think you just did. I think you
Yeah,
just did.
that was kind of it. No, but I will say this because I end almost every podcast that I do with this, which is that in healthcare in general, you have to be an advocate for yourself. This is especially true if you are a woman, and this is especially true if you have osteoporosis because your doctor doesn't understand it. I can almost guarantee it. And as a woman, you are not getting heard. I can almost guarantee it. So I think your audience is probably mostly women. So please hear me, advocate for yourself, get screened, know what's going on with your bones, and then make a plan to do something about it.
Amen to that. Dr. Doug, where can people find you?
If you have osteoporosis, the easiest way to find me is on YouTube, The Dr. Doug Show. If you look up osteoporosis on YouTube, I think I might be the first thing that pops up, which is
You
pretty
are.
awesome.
You are.
Yeah,
Yep.
I love it. I love it. That's great. So YouTube, we have 200 plus videos. It's all about how to reverse osteoporosis naturally. It is our mission. It's our passion. So that's probably the best way. If you want to learn about our practices, just go to optimalhumanhealth.com. That's sort of like the hub of everything. We do lots of stuff from hormone replacement therapy to reversing osteoporosis. So one of those two ways, and you'll find all the things.
And I want to add, if you are a practitioner listening to this, because we do have a lot of practitioners listening, and osteoporosis is not your area of expertise, which I can almost guarantee you it's not, go binge watch his YouTube videos. You will learn a lot on top of this podcast. So definitely dive in there no matter what. He's easy to understand, easy to follow. And like I said, you'll learn so much about bone and what to do for your own patients or yourself, as he said, if you yourself have osteoporosis. Well, thank you for coming on the Root Cause Medicine podcast. I always enjoy talking with you and I so appreciate it.
Awesome. Thanks, Carrie.